Okay, thank you. So, my name is Olumido Budausi. I work in Nigeria as professor of pharmacology and director of strategy at the University of Medical Sciences as the first medical university in Nigeria. And before that, I've had a very, very long history with TDR, starting from probably 1981, I believe. And over the years, I've seen TDR support LMICs along the way in building malaria research capacity. So it's very apt that we are here at the main conference because TDR, since 1997, when MIM was formed, TDR has played a big role in working together with other partners to establish MIM. And within the first 10 years of the MIM program and the MIM TDR collaboration with the other partners, TDR was able to support over 69 research grants to 36 African institutions and spread across 17 countries. And many of the grantees from those initial cohort of research are now playing very major roles in malaria as a whole. The leading major malaria initiatives and institutions across the globe. Some of them who are actually in the conference today, you will see have over the years been able to train several generations of PhD students. So in 25 years, TDR has had over 6 generations of malaria scientists with PhD after the initial cohorts, and some of those first cohorts of trainees, like I said, are holding very senior positions across the world. Today, TDR continues to do that, building malaria research capacity across the globe, and also supporting malaria research, as you will hear as we go on in this program. On the slide here, in the photograph there, you can see some of those trainees. Somewhere there, I am sitting there. It was taken in 1981, and that was one of the first MIM TDR grants. And the other people in this conference here, Professor Mbacham is there, and a few other people. So TDR has done a great work, and I am very happy to have the honor of being asked to co-chair this session today. Topoku.
Hi, everybody. So welcome. It's a real pleasure to see you all and also to meet new and old faces. So my name is Opokwa Oforenyinam. I work at GSK and I work in the newly developed Global Health Department within GSK. So part of our role is to try to change the trajectory of high burden diseases in lower income countries. So we work in terms of global health R&D. We have access, and we also have health system strengthening. So we have had a dedicated team, and we just try to function mainly on diseases of developing world, which include malaria, antimicrobial resistance, TB, etc., etc. Now, on this next slide, we've been partnering with TDR since 1981, if I'm not mistaken, or even earlier. We initiated this TDR fellowship program with the pharmaceutical companies. And at that time, it was because we were moving into Africa to do some major trials with our RTSS vaccine. And we're looking for like-minded individuals with the same kind of training to help us to make a study which was ethical as well as well done. And that was when we came to this block. There were just a few senior people who did know about research, but there was a big dearth in terms of upcoming investigators who could potentially be trained. And that's how we started this program. Currently, we've supported about, we co-fund the program with TDR for our program. And we've had about 20 who have worked on an RTSS malaria vaccine, and that's a real achievement. And if you look at some of these, when Professor Terras started working with us, he was a very young man, and now he's a big boss in MRTC. If you just look around, look at, what's his name? Roma Chilenge. He's now in charge of science and technology. So I think together with the theme of what we are doing at this meeting, it's important that we continue to partner with TDR, because without TDR, all of these people would not have been able to make their career. So then I'll just hand over to my co-chair to try and introduce all the people who we're seeing today.
Thank you very much. So there's nothing as great as having the dramatis personae speak to the subject. So we have a panel of our 4 speakers who will be sharing their experiences and talking about what TDR has basically done over the years and how TDR continues to provide this support in building capacity across the LMIC. Of course, the first speaker will be Dr. John Reeder. Dr. John Reeder is director of TDR, and he'll be giving us an overview of how TDR's approach to malaria research has evolved over the past 50 years. You will agree with me that a lot has happened in that period, and Dr. Reeder will put in some context to it when he gives his talk. And then Professor Jean-Louis Ndiaye from the University of Thiès in Senegal will come to talk about how research to support malaria prevention has gone on in West Africa and give some examples and experience from the work that they have done in seasonal malaria, chemo prevention, and vaccination. From Bamako, Mali, from the MRTC, a center that has collaborated with TDL a lot over the years, Dr. Fomon Sogoba, s'il vous plaît, will be speaking to us again about findings from recently conducted research on implementing a multi-sectoral approach in managing malaria in Mali, and there'll be lessons that we can learn from that and see that can be translated to other contexts also. And finally, from Suriname, all the other speakers the other 2 speakers being from Africa would cross the Atlantic to Suriname and listen to Dr. Stephen Redden from the National Malaria Program, Ministry of Health, who will talk to us about implementation of an innovative malaria detection and treatment kit, which they have called MalaKit. And he'll be sharing with us some of the experience that they've had in that domain in Suriname. So without taking much more of your time, Dr. Reeder, please.
Thanks, Olu. And I'll stand forward of the podium because obviously I'm not as tall as Olu. A little bit of a warning, though, I do tend to throw my hands. So all of you on the front row, watch very carefully because this is quite heavy. Could I have my slides, please? It's okay. I could sing, but you'll really wish to get the slides up. Aha. Let me start. Most of you know what TDR is, and it's a global program. I think some important points about this is it's co-sponsored across the UN. While we're at WHO, and people tend to think of us as WHO, TDR, it is actually co-sponsored. And we have our own independent board. So we're not WHO, but that board is formed of the countries, the disease endemic countries that drive us. You'll notice from all of the podiums and the stage, we've been going since 1974. I wish it was my 50th birthday, but unfortunately it's mine. That's long gone. But TDR is 50 this year. I was asked to give a little bit of the history, but history leads to today. So I'm going to start from today of what we are, and then we'll look a bit about what made us this. And where we are today is really well detailed in the strategy, and I hope you can go and chase this down. But what it's telling you are a few important things. TDR is now very focused on implementation research. It's focused on the capacity in the programs themselves to solve problems through research and actually improve the programs at the point. In some ways, it's democratizing the science we've already done, kicking out of just being an academic pursuit and putting it in the hands of practitioners at all different levels. We still are recognizable, though. You know, those of you who've known us for a long time will realize the long history of research support and research training, and also our advantage of being a cross-UN agency to be able to join the global debate and bring our participants into it. What we've done in this current strategy is try to focus on some of the big global health issues that we can contribute to. And you will see across this, malaria is still very much cross-cutting. In fact, one could argue it's in every single one of these pillars as we go through these aspects. Okay, so the history, that's where we are today. It's not always been the same. And this is really important. I mean, if you don't evolve, you go extinct. Ask the dinosaurs. You know, we started very much as a product development partnership. And in fact, I have to brag, we're probably the most successful with 13 products coming out of TDR to market. But we were just too good at that, so we thought we'd do some other things. Now, what happened is the landscape changed, and we had the product development partnerships. TDR was part of forming many of them, got much stronger in this area. So TDR evolved into looking at things like community-led approaches to control, how to get access to the most vulnerable, and most recently distilling this into looking at implementation science and taking this into the countries themselves. So you see, we've moved along, but within that, the same DNA is winding through this operation. What about malaria? Malaria is one of the first priority diseases of TDR right back to the formation. And you can see here just a few of the events on here. And these are quite significant events. You know, way back in the 80s, TDR funded the mefloquine studies. By 96, it was looking at the packaging of artemether lumefantrine and also sponsored the trials of artemisinin, which I'll come back to on here. And even relatively recently, as we've moved into implementation research, we haven't dropped these things, and we've been working very closely with MMV to take forward the results on rectal artemisinin into production and to try and make an impact. Thanks, it's quite an echo here. I hope it's better out that way. It's bad enough you haven't heard me once, I'm hearing myself twice. So let me just talk about a couple of the specifics from the past. And this is one I really want to focus on because it seems incredible today that people thought insecticide-treated bed nets were a really stupid idea in 1990. People just thought that was ridiculous, that it might work. And fortunately, one of those people was not Tori Gadal, the TDR director at the time, and he invested almost half of the funding for TDR into this project in the early 90s, so convinced he was that the investigators were showing promise in this area. And of course, TDR didn't do this work. It was done by many, and Pedro was part of this early on as well. Brian Greenwood, of course, in the Gambia doing fantastic work. But with that support, we really were able to get the evidence needed to make this obviously a mainstay of malaria control. So history is a funny thing. The younger people who think it's always been around, but at the back of this, things need the evidence. Things need to be proven before they can be taken into use. One of the other really successful parts of history is TDR invested in the testing of artemisinin-based combination therapies. Again, mainstay of malaria control program, but untested as late, as into the 90s here. So funding these in different countries really produced the results that made this go forward and become one of the mainstays of control. And in fact, a nice little aside to this, because of TDR's history in the area, I was fortunate to be invited to the 2015 Nobel Prize ceremony, where 2UU got the Nobel Prize for the discovery of artemisinin. Quite an event. So where are we now with this though? And this comes to this panel today. We're trying to put these two things together. We're trying to move on with our strategic directions, but still have impact in this way. So you see, for example, now our activities in malaria drugs have lent more towards the operational research behind seasonal malaria chemo prevention. And I think we're going to hear from that from a little later from Jean-Louis. We heard just a little earlier that while we are not vaccine development, over the years with our career development fellowships, we've funded over 20 into GSK as part of this. And the important point, and there might even be people in the room from this here, is not that they have been and done training at GSK. These are the people who are in countries now who are really capacitating those countries for the uptake of the vaccines. Now they're registered and now they're in wider use. And finally, we're going to hear of two other projects, just really highlighting some of where we are now with TDR and malaria, looking at multisectoral approaches to malaria vector control and really trying to make sure that we don't have a narrow view of this, and we're really realizing the multifactorial elements into this, and also trying to still reach the most marginalized, reach those populations that are, like I heard a great expression, I tend to say hard to reach, and somebody said to me, no, they're easy to ignore. And I think this is really important. So we're going to hear from Stefan a little earlier, one of the projects that's stretching into a very remote area. So thanks, and first thanks to the donors of this work. And I think one of the important points of the success of TDR has been donors that support our core research over long periods of time, not just the project to project, which means we can support activity in the field in a consistent way and do the things that are unpopular and unfashionable. Silly things like testing bed nets, silly things like seeing if artemisinin worked, stuff that wouldn't have got funding at the time. Really important to have core support that can be put into a strategic direction and move forward. Thanks to you for 50 years of support. Some of you, Olu, for example, who's been around for 40 years of that since it funded some of his training in those days. And I think other people in the room probably have a much longer history of this with me. And we look forward, perhaps not to the next 50 years, because we'd hope maybe we're out of business by then and we've got this under control. But I think we still have a lot to do, and we very much look forward to working with you in the future. Thanks.
Thank you so much, John. So we'll have Jean-Louis talk about the work in Senegal.
Thank you, Professor Olumide. So very pleased and very excited to celebrate with you the 50th anniversary of TDR, and thanks for inviting me to share a bit of my experience of working with WHO TDR around the malaria prevention research in West Africa. Just before starting, I just want you to help me and give a hand for celebrating the happy anniversary TDR. Thank you very much. So yes, I'm coming from University of Chess in Senegal. Here, this one. Okay, so why we are here is because malaria remains a leading cause of malaria deaths. We all know that in 50% of the malaria deaths occurring in 12 countries where are in Central and West Africa. So it's not really working. Yeah. So this is the reason why we are here is this because, we all know these maps. And in 2018, WHO analyzed the data and showed that the key indicators of malaria has really not really improved since 2015. And the need of full use of proven tools, and SMC was among them. And we highlighted the necessity of really creating this unique platform of collaboration with the National Malaria Control Program. So 13 countries implementing SMC with 2 academic, London School for Hygiene and Tropical Medicine and University of Chess, where I'm from, but also WHO TDR and also MMV. We really think about this, and this project is funded by UNDP starting in 2020 and probably will end next year in 2015 for 5 years, working closely with the National Malaria Control Programs. So the objective of the SMC, optimizing the delivery of SMC in order to increase its impact, is to really strengthen the capacity of the National Malaria Control Program. So we really work with them to identify the gaps in the SMC delivery, and from them we define research priority and help them to write proposal, give them small grants, thanks to EDCP, to conduct implementation research to improve the SMC effectiveness, how to also better interpret and make a better use of the malaria surveillance data, how to target the hard-to-reach population, but the high-risk population in those countries, and so the best period of the year where SMC will be very effective, and also monitor the delivery, the uptake, and the effectiveness of SMC. Of course, this platform of these 13 countries, you have some barriers, languages, we have Anglophone, Francophone, and Lusophone, but we promote the collaboration between the countries. Some coordinators are here. Also, how to share the best practice, the lesson learned, and also information and expertise among these countries. So finally, all these countries have developed some research, implemented research project, and they led their implementation of this project. So the country-led National Malaria Control Program implementation research project follow the 4 pillars: how to better monitor and evaluate, how to tackle the barrier of SMC uptake using qualitative studies, how to develop new strategies, and also how to adapt the target groups. For example, in Ghana, in Benin, in Senegal, this is how the different projects we develop with them. In the Gambia, also the assessment of the adherence. In Guinea, there was a low coverage in the mining area. So using the qualitative studies, we identify where are the gaps. So we also implement improved delivery approach. So Nigeria, and this study was also published. We helped the program also to publish these studies. Nigeria evaluate the barriers and facilitators of SMC. And Burkina also is looking why they have low coverage in urban area and what are the solutions to improve this coverage. So with the Mali and the Cameroon, we developed the same studies of identifying how to use new strategies, using community leaders, using household leaders to improve SMC compliance. And with the Niger, Togo, and Chad, we were thinking about developing and adapting the target groups of this. So WHO TDR is not supporting only the institution, but also, as Professor Olumide said at the beginning, there are also the support of the researchers, young researchers particularly. And I will give just 2 examples in Senegal, where where we are also continuing to monitor SMC drug-resistant molecular matter after scaling up. We scale up in Senegal since almost 10 years. And thanks for that, we have that young researcher, Isaac Manga, who defended his thesis last year. He's now recruited as a faculty member at the University of Dakar. Isaac showed, after following several years, the SMC scaling up, that the prevalence of mutation of amodiaquine is not really growing up with comparing to children under 5. Senegal is implementing SMC in children under 10 years old since 2014. And when we look at the frequency of this mutation in the children under 10 and over 10, we are seeing that there's not that much increase. So the amodiaquine is still working. And the same with the SP drug-resistant molecular markers with the DHFR and DHPS, showing that the quadruple mutation, as we all know, in many countries is very high in terms of prevalence and frequency. But fortunately, the quintuple mutation is still low. We don't see it in any survey, but very low prevalence in the incident cases in Senegal. We are also, thanks to TDR, following the IPTP. Yes, in IPT, we're monitoring also the efficacy of IPTP in pregnant women. Thanks to this, one of my PhD students, Marie-Pierre Diouf, is also following this. Marie-Pierre probably will defend his thesis in a couple of months in chess. And she showed a very interesting result showing that the parasite carriage, when we're using the RDT, which is a classic diagnostic test in Senegal, there's 20% of pregnant women are carrying the malaria parasite in the transmission season. But when we're using the PCR, it's almost half of the pregnant women are having this parasite. And this research has been really following with interest by the National Malaria Control Program. It's going to really see how they can be more aggressive among these women. And hopefully as well, the SP, the molecular markers of SP is not also going that much. So SP is still effective, but need to really see how we can better use it in Senegal. So I showed you this before, meaning that also child survival really improved, but there's still a lot of malaria, still a lot of children dying from malaria. So that's the reason why we work a lot with SMC countries. They now make full use of the SMC. They really know how they can optimize it, and you can see they are really adapting the SMC strategy following the malaria epidemiology from 3, 4, or 5 cycle in many countries. Some of them are also starting increasing the age range, geographical expansion, demographic expansion, also increasing number of cycles. But despite all of this, we are seeing that there's still a need of additional tool because there's still a lot of deaths due to malaria. So just John showed it previously. We are working with using that platform of SMC. We are looking for how to really help the new malaria vaccine. There's a historical news since 2021 with the RTSS vaccine, a revolution in medicine. The first time we have a vaccine against a parasite and against a malaria parasite, P-falciparum. Last year, we have also the WHO recommendation for the R21. Hopefully, with the MV project, we have several years of experience of using RTSS in Ghana, in Kenya, also in Malawi. But this country has a very good immunization coverage. So working with the country, working with the platform of SMC, we have organized webinars and meetings the last 2 years where we discuss with the country on the malaria vaccine characteristic, but also the specificity of the context of West and Central Africa, where malaria is highly seasonal, and what are the implementation challenge, and also what opportunity we could have with these 2 vaccines. So these are the challenges. Hopefully for the vaccine to be really effective, it should be implemented through the API program. But we see that in many countries, there's very low uptake of basic vaccine, especially in the second year of life, because these vaccines need a booster dose in the second year of life. So you can see, for example, given the example of Nigeria, you see that for the measles vaccine in the second year of life, the coverage is very low, it's 9%. You have 31% of children from 12 to 23 months where there's no vaccination. So these are the very challenges that countries should take into account while they are starting now to receive the vaccine in their countries. We are seeing also there's opportunities, because when we combine the intervention, it's really show that when you combine SMC plus the vaccine plus a good coverage to ITN, you can read out 92% of cases. So this is very good news that combination of intervention very well used in the country could really reduce 92% of cases. That's the reason why using the OptSMT platform, we create this new project called OptMVAC, which is optimizing the malaria vaccine project in those countries. The overall goal is to improve the delivery, the deployment and uptake of vaccines through implementation research, using exactly the same scenario as the OptSMT using in the 4 last years. The objective is to support the countries technically and financially, and really to optimize malaria vaccine delivery using the series of methods, mixed methods, qualitative and quantity, to inform the vaccine delivery strategy. Using coverage survey, helping the country to develop those coverage survey for the malaria vaccine, but also for the other vaccines, to look at, to understand really the barriers to the vaccine uptake using the qualitative studies, but also doing health economic evaluation. This OptMVAC will have a very strong domain of pharmacovigilance using the safety of the vaccine, but also case control study using morbidity and mortality data. This project is we developed it. We just funded up to the EDCP. We just submitted to the EDCP3 call. We hope to receive good news in the next year, but if not, I think there's sufficient people here who can help us, like Pedro or like Peter or John, to help us to find more funds for these projects. Really, the idea was really to use the OptSMT platform. So this is my last slide. I will just finish to thank all the people who helped me during those studies, the donors, the institution, but of course, ensure WHO TDR for this full. Thank you very much.
Thank you very much, Jean-Louis. We'll take questions after the last presenter. But again, you've seen how he's demonstrated, shown one of the hallmarks of TDR is you do the research, and while you're doing the research, you're also building capacity along the way. So I'll call on Dr. Suguba from Bamako, Mali, to come to tell us about some of the work that's been done there, also in the multisectoral approach to managing malaria.
Can you show me how to? Okay, thank you very much. It's my turn also to wish happy birthday to TDR. And it's also an honor for me to stand and to talk about a project which is funded by TDR as implementation research. It's a pilot study we are carrying in Mali and in West Africa, I can say, because it includes Mali, Burkina Faso, Benin, and Nigeria, to try to see how a multi-sectoral approach can be used to control malaria and mitigate insecticide resistance, and also to address the wash issues. Since 2020, TDR have published a conceptual framework on the essential element of successful multi-sectoral collaboration. And you can see this at your right side. And TDR is now funding project to address this. And actually, next, please. Someone is wishing. I don't know. Okay, our project was built on a certain number of elements, which are, most of them are environmental based. We are very excited to see that the current control tools are reducing the malaria burden, but we still have some residual transmission which are sustained by certain elements. If we don't address them now, this can be some bottleneck to eliminate malaria. Among them, we have the rice cropping, which is for food need, especially during the dry season. And most of control intervention are focused on the rainy season, but mosquitoes still breeding in the dry season in rice cropping areas. We also have the agricultural sectors, which are overuse insecticide, which can also contribute to increase the spread of insecticide resistance. And naturally, also, we have the environment For instance, in Sahelian area during the dry season, all the rivers are receding and create small water pools where mosquitoes spend all the dry season breeding and maintaining transmission. These areas are not yet targeted by intervention. We have also the quality of the net which are sold in the market in Africa, which may not have the necessary ingredient, which can also affect the effectiveness of this tool. And lastly, we have the wash condition in the health sector, because the wash condition can also create a breeding site in health center, which mosquito can use to breed. And this pilot study is looking how using the multi-sectoral approach, we can try to focus on some of these environmental issues. Okay. Anyway, this was just to show you the study site. It is in Mali, in Burkina Faso, Benin, and Nigeria. Okay, to now implement this project, we needed a collaboration with the environmental sector for the vector control. And for that, we mapped the breeding site in the river bed, and with the collaboration with the community, we physically destroy the larval habitat when they were small pools, but we use the biopesticide to treat the large one. We also identify mosquito swarming markers in these areas, and with the communities, we destroy this swarm at the onset of the sun at sunset, using the pesticide which has been shown to be killing the mosquito. And also for long-lasting net, for mosquito resistance, we perform a susceptibility test using WHO bioassay method. And also we collected mosquito when the intervention was going on. We collect mosquito also in human dwelling around the study areas to see how our intervention can impact on mosquito densities. And from this part of the study, we've been in Mali able to identify more than 1,500 larval habitats on which we intervene, and these were consisting mainly on brick pits and also the small water puddle in the river bed. We've been also able to identify more than 800 swarming places, which were also being destroyed every 2 weeks during 3 consecutive days. And the Anopheles gammae susceptibility, it showed a moderate to high resistance to deltamethrin, and partial restoration was observed with PBO. And the main finding is that in the hamlet around the river bed, we observe a 66.7% of reduction in mosquito density in March and 61% during April, which is the peak dry season in Mali. And from this, what we can learn is that during the dry season, Anopheles mosquitoes are breeding in brick pits and water pools along the river, and community intervention combining larval source management and swarm killing reduces mosquito density. We collaborate also with the agricultural sector to try to assess a best use of pesticide against the farmers' practice. For that, we set up an experimental design for pest management, and we have a control area, which is farmers. They are using multiple insecticides to take care of their vegetable cropping, because it's the dry season, and we set up an optimal combination of different pesticides to compare this with what the farmers are using. And the treatment was done by spraying the vegetable, and we collect, we monitor the cabbage growth. We also look on the presence of insect on the cabbage, and also we assess the increase, the yields, the increase of the yield from this. And also we look at on the, in the soil, what is the residue of pesticide which can be observed in the experimental condition compared to farmers' practice. And from this, we see that we have lowest cabbage infestation in experimental use, good practice of pesticide use compared to farmers one. And we have no significant difference in some, we have the different study areas. In some area, we have no significant difference. In other areas, there was a variability in the agricultural yield, but we found that in the experimental pesticide use, best use of the pesticide, we have 50% of reduction in pesticide residue in soil compared to farmers' practice. And from this study, we can say that the combination, which is hematocot and lambda pesticide formulation, were the most effective against the pest of cabbage compared to the multiple insecticide used by farmer with lower pesticide residue in soil on vegetable, potentially reducing mosquito resistance and minimizing health impact. Okay, in Nigeria, we assessed the long-lasting quality by collecting long-lasting net in different point of sale in Lagos, and we evaluate their effectiveness against Anopheles susceptible strain of Anopheles gambiae in using the cone test. And we also extracted from the different net the pesticide using the HPLC machine. And we, for the deltametrin, we use the isooctane dioxide method. And for the alpha cypermethrin, we extracted using the Zelen method. And all the residue of, or the quantity of pesticide was assessed using the HPLC machine. And from that, fortunately, we fortunately, all the bed net we collected show 100% mortality, 24-hour post-exposure, but alpha cypermethrin demonstrated highest knockdown rate at 3 minutes. So then we conclude from this that all the net tested show optimal concentration of insecticide, suggesting that long-lasting available at point of sale in Lagos have strong bioefficacy against susceptible population of agami. But to make the long-lasting more useful, efforts should be focused on increasing the interest of the inhabitant in using them properly. Okay, we also assess the wash approach, the wash condition in our study site. We use multisectoral approach. The social scientist was conducting the wash condition while we were addressing the entomological part of the study. And in this, we use both quantitative and qualitative method. And also for qualitative, it was in-depth interview. For group discussion, we use focus group. And for the quantitative data collection, we use semi-structure questionnaire to collect. From this, the main finding were that wash conditions vary in Mali and challenges persist in waste management and provision. In Benin, latrines were inadequate and challenging access, especially for people with reduced mobility. And in Nigeria, wash conditions are reasonably good, but a recommendation for a regular tank is necessary. For Burkina, we have really a weakness in wash service in all the health centers. Okay, this work was done in collaboration with the different national control program of Mali, and we built up our multi-sectoral task force on the existing vector management program in each of the country. And the key finding from this project is that we have a reduction in Mali, a reduction of mosquito density. In Burkina Faso, we have a weakness in wash. In Benin, we found a good formulation of pesticide use can improve, can reduce the residue in soil. And in Nigeria, we tested the net, which are a good quality, and effort should be put on the best use. So for the multi-sectoral approach, we have some strength which increase during our project. It increased the community awareness and participation in larval source management. There was the availability of diverse water sources which ensure a steady water supplies in the health center. And it also improved collaboration with other non-health sectors that contribute to multiple benefits. The opportunities were that there are opportunities for educational program, investment in water infrastructure, involving communities in wash initiative, and leveraging technology for water treatment and waste management. The weakness are that we have difficulties in synchronizing program of different stakeholders, limited wash knowledge by the community, insufficient sanitation, inadequate latrine and facilities. We have also water quality concern, and we have inconsistent waste management. The trick is how to map the success of our intervention to the multi-sectoral approach pillars, how to maintain the multi-sectoral advisory task force after the end of the project, and how to ensure research results are taken up in policy makers, especially in the case of cross-sectoral aspect. So thank you for your attention. Okay.
Thank you so much. Sometimes there's so much data, you will have to struggle to squeeze it in within the 15 minutes time slot you have allotted. Now we're going to go across the Atlantic to a different context in Suriname. I'd like to invite Dr. Stephen Redden to come tell us about the experience with the National Malaria Program in the Ministry of Health in Suriname.
Okay, good afternoon, everyone. I'm Stephen Vreden from Suriname. First, I would like to congratulate TDR with its 50th anniversary, but also thank them for inviting me from a completely different region to present on this wonderful conference. The subject of my presentation is about innovative methods in controlling malaria, but it wouldn't make sense to talk about those innovative methods without placing them in a certain perspectives. So first, I will say something about Suriname and its approaches to malaria elimination. Okay, so where is Suriname? Because so many people from this continent don't even know. So we are not in Africa, we're in South America. In fact, Brazil is our southern border, southern neighbor. We are a country that is blessed with a lot of rainforest still. More than 90% of the country is covered by rainforest. and that leaves quite little room for people. So we have less than 600,000 people in the country. Those less than 600,000 people live mainly in the coastal area where there's no malaria transmission. We have about 80,000 people from indigenous and tribal populations in the forest, indigenous that are Amerindians, originally from South America, and tribal populations are, in fact, the slaves, enslaved people in Suriname who fled the plantations and then kept living in the interior. So they've been living there for quite a few years, more than 2 ages. Okay, but on top of these 80,000 people in the forest, we also have about 20,000 mobile migrants who are mainly involved in artisanal small-scale gold mining, and they are primarily from Brazilian origin. Suriname is, by the way, a low middle income country. So the medical care in the interior of the country is provided by an organization that we call Medical Mission Primary Health Care. All the green spots you see are the places where we have clinics from Medical Mission in the forest, and they provide medical care to these populations. Unfortunately, for the mobile and migrant populations, there is no health access, no formal health access, other than moving to the capital or to the facilities. This is a map indicating the movements of those mobile populations. You see that they move from Brazil into Suriname. They move from Brazil into French Guiana, that is our eastern neighbor, or they move from Brazil to Guyana and into Suriname. Guyana is our western border. There's even some movement from people from Venezuela, because Venezuela is bordering Guyana, and so we even have people from Venezuela entering our forest. In French Guiana, gold mining is done illegally by these people because they enter the country. In fact, it's a département outre-mer, an overseas department from France. And so these people, they enter the French forest illegally, and they start mining there illegally. And this causes quite some problems with the French authorities. Maybe I'll say something about that later. Sorry. Yes. So this is the malaria situation in Suriname in the past 50 or so years. So we've had malaria prevalence, malaria incidence of about 4,000 cases per year, but we have had a civil war in 1986 lasting to 1992, and this led to an enormous increase of malaria cases, which lasted even after the civil war had ended. We were only able to reduce the number of malaria cases in the early 2000s when we introduced some specific measures funded most of the time initially by US aid, but later also by the Global Fund. And what was very effective was the use of rapid diagnostic tests, but also the introduction of ACT. This reduced significantly the number of cases of malaria in Suriname, and in fact, it eliminated the malaria from the villages of the tribal and indigenous populations. So where we still had malaria was in this population of migrant gold miners. And to approach that, we introduced a system that we called malaria surface deliverers, specifically for this gold mining region. Okay, so what are malaria surface deliverers? These are people who are from the mining community and who we recruit to be trained in basic malaria knowledge. So they got some information on pathogenesis and symptoms, They were trained in making doing RDTs, in making slides, not staining them, just preserving them. They were trained in adequately issuing anti-malarial medication, and they had to report to the central level. And they were also participating in malaria screening missions, because what we regularly did in those gold mining areas, we screened everyone for malaria and treated them. It's what we call active and reactive case detection. I must say that the deployment of MSD contributed significantly to malaria elimination from Suriname's gold mining fields. But first, I have to show that the species that was involved shifted from being mainly falciparum to being mainly vivax, and that is partly related to the fact that malaria was could not be reintroduced. It was never occurring in people from African descent. It was mostly in people from the Amerindians, but also in the Brazilian miners, because of the Duffy antigen problem that I'm not going to discuss. Okay, so what remained as a problem in Suriname was reintroduction, because I said those mobile migrant population was moving into the French forest and coming back. In the French forest, there are no health facilities, there's no treatment. So what these people did was using counterfeit medication and using it as short as possible, because they were buying it at a high price. And this was a threat of reintroduction of malaria into Suriname, and that's something that we did not want. And then, together with our French and Brazilian partners, we started a project that we call the Malakit project. The Malakit project, the approach is that we instructed the trans-border gold mining communities to self-test and treat malaria. We provided them with testing materials and with treatment courses, and we did a pre- and post-intervention survey about the knowledge, attitudes, and practices of these populations, just to know what the impact of Malakit would be on their knowledge, but also on the malaria imported from French Guiana into Suriname and into Brazil. So this is the Malakit. I have issued 2 packages that can be passed around so that everyone knows and sees what the Malakit is. But in short, it is a kit that contains 3 rapid tests, and in order to avoid complexity, we were not using any distinction between vivax and falciparum, and we also provided a course of coartem. Okay, so the procedure was that we advertised the project to the target population. We enrolled them with informed consent, because this was a study. We provided one-on-one malaria information to these people, instructions on how to use the kit, instructions on how to interpret the results and to act upon the result. We then provided them with a test kit, and we also downloaded the instructions on their mobile phones, because these people, most of the time, they are functionally illiterate. So it was good to have this information on their smartphones. So the results here, in short, in the 2-year period, 2018-2020, we issued almost 5,000 kits to almost 4,000 people. In our pre and post survey, we included over 1,000 people. What we found is that the percentage of the number of cases of malaria that were introduced from French Guiana into Suriname, but also into Brazil, decreased with 43%, but this cut was mainly in falciparum cases, which is logical because the treatment was aimed at falciparum. And we also found that there was a significant increase in the number of people who before taking medication, would do a test, because before they just took medication whenever they thought that they had malaria. So that was a good thing. So this innovative national project shows that people with little education can be effectively treated to self-care for malaria and change their behavior. And I think that this strategy could be eventually implemented in other regions that are facing similar situation. In 2020, the Surinamese Ministry of Health decided that Malakit would be included in the tools towards malaria elimination in Suriname. Okay, but as I said, we didn't had much influence on the P5X cases with Malakit. So that's why, together with Brazil and French Guiana again, we started a new project that was called CUREMA. This CUREMA project has 3 interventions. The people could opt for just getting a Malakit, as I said before. They could eventually get a treatment course for P5X, even if they were negative, but only if they had been residing for some time in an area with P5X transmission, which was most of the time the French forest, because Suriname is virtually free of malaria. And they could also opt for both of these 2. This study was is funded by the Centre Hospitalier de Cayenne. It was launched in March 2023 and will last until the end of this year. And it's, of course, aimed at artisanal gold miners in the Guyana Shield. I'm almost there. Okay, about the procedure. We advertised the program, the project, just as we did for Malakit. We only gave the people Primaquine if they had a confirmed adequate level of G6PD. And for that, we were using this quantitative G6PD machine that was being used prior to giving this medication. And as before, we assessed the impact on the import of 5X cases. The results of this study are not available yet. Okay, this is my pre-final slide. So summarizing, in Suriname, while we are eliminating malaria, it is challenging that there can be reintroduction from the neighboring countries, because all neighboring countries have relatively high malaria incidence. We implemented innovative methods such as the malaria service deliverers, Malakit, but also CUREMA. And we think that it's pivotal that there is regional integration in malaria control and elimination, because as one country surrounded by 3 other countries that still have a malaria prevalence, it will be very difficult to maintain your elimination status. Since September, by the way, since September 2021, Suriname has 0 local malaria cases, so we're almost there with 3 years. I need to mention the contribution of TDR to this project. They specifically supported the binational collaboration between Suriname and French Guiana by being involved in explaining the drug resistance to the mining population. They also supported the integration and evaluation of the G6PD testing. And in 2021, we had an international meeting about malaria, in which we tried to design guidelines for remote populations. And finally, there is a cross-regional application going on where TDR, together with our French counterparts, is exploring the possibilities of transfer of Malakit technology into Senegal. Thank you.
Very much.
I
Take it around so that
Yeah, okay.
So I'm sorry, because of all the technical difficulties, we were not able to start on time. But I just still want to thank you for coming to this. So you heard about the wonderful work TDR has been doing in partnering with different people. I talked about the capacity building and how all these people are working in different fields. That is an example of a TDR PhD person, and look how far he's gone. Dr. Rita talked about TDR. You talked about the work on SMC, you talked about the work in vector control, and your wonderful work also about trying to eliminate malaria from TDR, from Suriname, sorry, and all this in partnership with TDR. So therefore, now it's time for questions. And I think, Pedro, I'm going to give you the privilege, because you are also a product of TDR. Your work started from the beginning up until you were the head of TDR. So, do you want to give a few comments, please?
Well, thank you. But first one is I didn't end up being the head of TDR. That's John Ritter.
Sorry.
No, thanks. No, some very brief comments. I'm a big cheerleader of TDR. Personally, I think it's been, or probably is, the most successful research organization. If you consider the last 40 years, what they've been able to deliver on a relatively small budget, and you compare it to what other much better funded organizations are achieving, it's the comparison is really on the good side of TDR. Impressive, the slide that John showed, how they've contributed to bednets, they've contributed to ACTs, they've contributed to so many things that are really the backbone of malaria control today. And no other organization has done such a thing, just on the side of malaria, let alone other things. And they've done so while in parallel strengthening research capacity in Africa. And I think it's the combination of these two things that makes TDR such a special organization that so many of us carry on in our heart. On a personal historical note,
That was what I wanted to hear.
so the historical note, John presented the role that TDR played in the 1990s in performing the 4 large-scale insecticide-treated bednets in Africa that established insecticide-treated bednets as the backbone of malaria control still today. That's not a small feature, but there's a prehistory to that. And the prehistory to that speaks to work that was going on in the 1980s in several parts of Africa, but also in Asia and in China, where different trials showed rather mixed results on the role of permethrin-treated insecticide bed nets. And the first time I was ever attended a meeting in Geneva must have been 88 or 89, where there was a review of the evidence available at that point. And the conclusion was, and I can share the WHO document that says this, is it is unlikely that insecticide-treated bed nets will ever become a significant form of malaria control in Africa. Well, that's how wrong can one get things. But in the face of that assessment, Tore Godal and TDR decided to go on investigating insecticide-treated bed nets, and that was the trial I was involved in which we were testing insecticide-treated bed nets plus minus what is now called SMC, at that point we called it targeted malaria chemoprophylaxis, but it was exactly the same concept. And the only one bright idea I think I ever had in my life is that we maintained a control group of bed nets, which in the Gambia at that time were used, but not treated with insecticide. And the results of this we published in Lancet in '91, showing that insecticide-treated bed nets had a massive impact on mortality. And that's what really changed the entire dynamics, and that then led to further investment to confirm those results, which indeed were confirmed, and bed nets becoming the backbone of malaria control. So the enlightened leadership in TDR, the scientific mindset, being ready to take pets, informing public health. That is something pretty extraordinary of what TDR and its leadership, going back to Tore, but very much today still with John, has shown the way. And all of that while training people. The first time I actually went to Accra was in '87 to recruit the first TDR fellow, Moses Akins, that worked on those insecticide-treated pet nets. So a small remembrance from very far long history, but I think still showing what an extraordinary work TDR has done and continues to do. Thanks.
Thank you, Pedro. So I think we have time for two things. So I'm just going to, because does anybody have a burning question? Other than that, I'm going to be wicked. I'm just going to call people too. So I think I have here a lady who is who has a TDR fellowship. And I'd just like you to, just a few words to comment on what you think it has done for you and where you want to go. 5 minutes, just 2 seconds.
We promise not to listen.
Just 2 seconds, it's okay, go ahead, it doesn't have to be.
Okay, so thank you so much and good morning, everyone. My name is Fatimata Sall. I'm from University of Thiès in Senegal, and I'm currently a TDR fellow at Luxembourg Institute of Health for the Clinical Research Leadership Fellowship. So I have started early on January this year, and I will stay there for 1 year. So, yeah, thank you very much.
And then I'm going to put Isaka. I'm putting you on the hot spot. So can you tell me how TDR has contributed to your development and research in your institution?
Sorry, I'm Isaka from Burkina. I think I worked with TDR early in my career in 2004, where we were working on schistosomiasis. After that, I don't have any more. I didn't continue like that with TDR.
But you did, what did it contribute for your research?
Yes, for sure, it gave me some experience in field studies and field working on schistosomiasis and diagnosis.
The reason why I selected him, 1 minute, yeah. The reason why I selected him is just to show how TDR work, the diversity of what he does. He learned about schistosomiasis through a TDR grant, and now what is he doing? He's doing malaria research. Again, it goes back again to what TDR does. It takes something small, it builds it up, and then it spreads it into other fields. So you had a comment, please.
Thank you. A comment. And since we're talking 50 years, I just wanted to complete the other side of what Pedro said. The change to ACTs was TDR. Moving the treatment from chloroquine to ACTs were work done by TDR preliminary in countries where we started mixing drugs and POCO packaging. The whole idea of unit treatment dosing and all of that was TDR.
Thank you so much. So then again, I think we should, I'd like everybody to give a hand to TDR because I think they are underappreciated. And in a lot of ways, they are taken for granted. But if you look at what they do, I mean, it is really impressive. And as Pedro said, with little money, but with a lot of vision and a lot of also partnerships, see what they've been able to contribute to malaria. Thank you so much. So now the other thing is, we'd like to invite everybody who's done any TDR work to come and join us here so we take a picture so that then this can be used for the 50 years of TDR. So thank you very much. So thank you very much. Thank you. Thank you. Thank you. And thank you so much. And it was a pleasure seeing you all. So please come and join us here. Let's take a picture and then celebrate 50 years of TDR. Thank you.
You shake it.
You do this after them. Very good.
Happy birthday to the TDR family. It's been 50 years of building, I think, the most incredible capacity in a very, very important area of work. And UNDP is very, very proud to have been on that journey with you as a founding co-sponsor. Happy 50th TDR.
Happy birthday. I remember my 50th with pride. You're just getting started. Best wishes for the future.
This year, the World Bank is really thrilled to be celebrating TDR's 50th anniversary. Together with other co-sponsors, the World Bank is committed to continue to support TDR as they embark on another 50 years of impactful global health research, enhanced in-country research capacity, and social innovations that would empower the most vulnerable and the poorest. Congratulations.
On behalf of Unicef, one of the 4 UN co-sponsors of TDR, I would like to wish TDR a very happy 50th anniversary. We would like to continue our collaboration in research and make sure new innovations reach to those who need them most.
Well, on behalf of the Luxembourg Ministry of Bilateral Collaboration, I would like to congratulate TDR for its 50th anniversary of its activities and wish it a lot of success for the future.
I'm very happy to be here today to commemorate with the President Director of TDR, John Reeder, and with the Director of the World Health Organization, this ceremony for the 50 years of life of TDR. Something which is not very well known, and I think was very important, was the role of TDR in creating new organizations. TDR was a key actor in the establishment of 4 product development partnerships, and I'm going to nominate one by one. In 1999, Medicine for Malaria Venture. In 2000, the Global Alliance for TB Drug Development. In 2003, DNDI, Drugs for Neglect Initiative, and FIND, the Foundation for Innovative New Diagnostics. The creation of these 4 organizations outside WHO, but very closely related to WHO, was really something very important. And we see today how they became important in this drug development.
Wow, it's 50 years already. Congratulations, TDR. I believe I've walked the journey with you for more than 30 years, and it's been a real pleasure. As we roll out the new strategy, I look forward to us engaging more and more to be able to deal with the tropical diseases of poverty. Congratulations and happy birthday.
As a student, 30 years ago, that was founded by TDR, I just wanted to wish a happy anniversary to this wonderful organization that has empowered numerous scientists across the planet to reach their full potential. So, happy anniversary.
Happy 50th birthday, TDR. We, the UK government, is very excited to have partnered with you for so long, since the very early days of TDR. Thank you so much, TDR, for all the research that you've done and for all the results that you've brought about.
Congratulations, TDR, on your 50th anniversary. And thank you very much for giving support to Brack James Spigner School of Public Health to promote implementation science capacity to its master's student.
TDR has been changing lives of individuals and communities for 50 years. So we're looking forward for the coming decades to continue this journey with TDR to change the lives of individuals and communities through local research solutions for improving global health.